As we first showed you in a series of reports by inewsource reporter Joanne Faryon, patients who have a terminal illness but live for weeks or months longer than expected with curative medical treatments can break a hospice provider's budget. Here to talk about how the Medicare Choices grants and their potential impact could be are Dr. William Mitchell, oncologist and director of UC San Diego's palliative medicine, and registered nurse Susie Johnson, VP of Sharp Hospice Care. Dr. Mitchell, let's start here. What's the difference between hospice care and curative care?
So, well, I might first draw a distinction between curative and life prolonging. Even though curative care may not be possible, we frequently use life prolonging treatments. And typically, hospices can't afford to pay for and don't provide expensive life prolonging treatments, although hospice care itself can be life prolonging, but not in a direct disease focused
So
way.
for instance, like chemotherapy or radiation to shrink the tumor even though it's not going to cure it?
Correct.
Okay. What choices do patients have right now when it comes between choosing hospice or palliative care and something else like this life prolonging treatment? Do they have that choice right now? So
there is a choice. It's frequently a very difficult choice because we have tied hospice eligibility to a short prognosis. Patients frequently are stuck choosing between those two, and sometimes that's a catch-22.
And Susie, how long does somebody typically stay in hospice, and is there a waiting list for people in San Diego to get into a hospice program?
Well, interestingly, the national statistics are that the average length of stay in hospice is slightly over 60 days, 2 months, and the median length of stay is about 15 days. So the Medicare benefit actually allows for people to be on hospice up to 6 months, assuming the normal course of the disease. We're not meeting that at all in our country, nor are we in San Diego County. So I think Medicare's decision to do the Medicare Choice program here is to really help maybe identify how we could change that by giving people choice. It doesn't have to be either or, you either go this pathway or that pathway. I think Medicare is trying to solve this problem.
Right, and that leads me to the next question about how does it work at Sharp? Your program is very similar to this proposed Medicare program. How do you, the Sharp transition program, how do you guys operate that?
We have a home-based palliative care program that's disease-specific for heart failure, COPD, dementia, advanced stage cancer, and geriatric frailty, where we took the Medicare coverage criteria and moved it upstream a little bit for heart failure, for example, and said, we can manage this population better at home, and we can stop the revolving door of hospitalization, emergency room visits, where people are using that as the primary tool for symptom management and when they get into trouble. When we go out into the patients' homes and provide an interdisciplinary coordinated care approach and give them options for their care, they are going to choose what works best for them, and that typically is stay at home.
Would you say that's working?
It's working extraordinarily well. We have really robust results demonstrating that through our program, we've reduced all-cause hospitalizations by nearly 60%, hospitalizations for heart failure by 94%. It's really challenging to get those statistics elsewhere based on the current care models, and that's what Sharp is working very diligently at Care Continuum.
Okay, and Dr. Mitchell, does that sort of indicate to you that what you would like to see with this Medicare program as far as the palliative care and expanding it or trying to do the life-prolonging treatments?
Well, so absolutely. The package of care that's available from a hospice is it's very unique and really, really supportive. And it's available only to a small subset of patients, and if we could offer that set of services, that level of support to many, many more patients, I think we would see amazing outcomes similar to what Susie's mentioned.
And what about the cost of doing this? How could you see this being covered?
So I believe that's been the sticking point, the concern that life-prolonging treatments are expensive, and hospice care with all of its features is expensive, and wouldn't that add up to even more money? There are emerging data that show that actually this overall saves money in the long run. It's a win-win-win. to provide these packages of care together.
And Susie, is Sharp going to apply for one of these grants?
We're seriously considering it. We would be probably remiss if we don't apply for it, because we are going to be able to show the Centers for Medicare and Medicaid that we have already a sustainable program
In place. All right. Well, a lot more on our website, kpbs.org. Susie Johnson and Dr. William Mitchell, thank you so much.
Thank you.
You're welcome. Thank you.